Hey everyone, welcome back to the Real Life Pharmacology Podcast. Thank you so much for listening. As always, I am Eric Christensen, pharmacist, who's been in charge of this podcast for, I believe it's almost 7 or 8 years now. So hope you're benefiting from it. Always remember, go back, check the archives. I've done over 400 individual drugs now. So if you're looking for a little more depth specifically on some medications, maybe a little deeper dive into kinetics and drug interactions and things like that, don't hesitate to go through the archives at reallifepharmacology.com. Hit the search button there and go check out the drug that you're particularly interested in learning more about. All right. While you're at reallifepharmacology.com, go check out the 31-page PDF. It's a top 200 study guide. Great refresher, great prep tool for exams and things of that nature as well. So again, reallifepharmacology.com, go get that free 31-page PDF. All right, we are going to cover aldosterone antagonists as well as direct-acting vasodilators. Continuing on our antihypertensive role here, first I'll cover aldosterone antagonists. So if you remember what aldosterone does, probably the simplest way to put it, and probably the easiest way for you to remember, is it allows the body to hold on to salt and water, and it dumps potassium out of the body. Okay, that's what aldosterone does. So now when we're talking about aldosterone antagonists, think the exact opposite. They are going to cause the excretion of salt and water, namely sodium as far as that salt goes, and we are going to retain potassium. This is why they are called potassium-sparing diuretics, or they're in that bigger, broader category. That's why they're called that. So again, that aldosterone antagonist mechanism, that's how it works. With more sodium, with more water going out of the body, leading to that mild diuretic type effect that can obviously help lower blood pressure. Now, the big risk with this medication, you will absolutely be tested on it. So the two meds in this class are spironolactone and eplerenone. In all honesty, I do not see eplerenone used very often. I think there's a lack of provider familiarity with it, as well as cost potentially being an issue too. But you got to remember hyperkalemia risk with these agents. And more specifically, if patients have a potassium level of 5 or above, we're probably going to want to avoid using an aldosterone antagonist. It's going to cause that potassium to go even higher. Obviously, put our patients at risk for clinically significant hyperkalemia. So that's one of the first things to know. Highly testable. You got to remember potassium and its effects on potassium. Okay. Also, pay super close attention if we're on other meds that can raise potassium levels. ACE inhibitors, ARBs, potassium supplements, and so on. Okay. Really important to remember that. This class of medication, I would say specifically more so spironolactone, is often used in resistant hypertension. So again, those first 4 classes are typically used first or tried at least. So you got your ACE or ARB, one of those on board, and then your calcium channel blocker, and then your thiazide diuretic. And then next in line often for many clinicians is the potassium-sparing diuretics or the aldosterone antagonists like spironolactone. Other things it can be used for. It can have some mortality benefit in heart failure with reduced ejection fraction. Okay, so that's a good one to remember there as well. And you'll also see it used in cirrhosis with ascites, that fluid buildup. Okay, and one of the reasons in ascites why it's used is aldosterone levels are typically elevated in patients with liver dysfunction. Spironolactone can cause endocrine-type side effects. Most notably is probably gynecomastia. So this is an enlargement of the breast, particularly in males. it can cause reduced libido and impotence as well. So those are probably some of the biggest downsides, particularly when using this medication in males. In females, it can lead to menstrual irregularities as well. So those of childbearing age, for example, that can be problematic there too. Eplerenone, I'll touch on it briefly here. It actually is a little more selective, and it doesn't have as much gynecomastia and things associated with it. But we still have the other risks associated with it, like hyperkalemia, for example. All right, renal function is important. This medication is contraindicated in patients who have creatinine clearance less than 30 mils per minute is the typical cutoff for not starting spironolactone. Otherwise, look at serum creatinine. And typically in men, that threshold is 2.5 creatinine or higher. We're going to generally avoid the use of spironolactone, and greater than 2 in women there. So pay attention, need to check renal function prior to initiating spironolactone. The other thing I wanted to touch on a little bit with lab monitoring is when we start this medication or when we increase the dose, typically we are going to check that potassium and check that serum creatinine within probably a week or 2 at the latest, just to make sure that those labs are stable and everything is okay. All right, we will move on to direct-acting vasodilators, but before we do that, be sure you go check out the sponsor, meded101.com/store. There's tons of resources there for your board exams, whether it be NAPLEX, BCPS, ambulatory care, geriatrics, and others. All those links, all those resources you can find at meded101.com/store. We've been putting together study materials for well over a decade now, helped thousands of pharmacists and pharmacy students prepare and pass their board exams. So go check that out, meded101.com/store. In addition, we got tons of other resources as well for nurses, med students, dietitians, lots of different books and resources available at meded101.com/store. All right, direct-acting vasodilators. These directly relax arterial smooth muscle, really don't have a ton of effect on the veins. Ultimately, with that relaxation of arterial smooth muscle, we can reduce systemic vascular resistance, and when we reduce that resistance, obviously we can drop blood pressure. There's a couple of proposed mechanisms that this happens by. Can potentially be by increasing nitric oxide signaling and or potentially inhibiting calcium release in vascular smooth muscle. The two main agents here are hydralazine and minoxidil. I don't see minoxidil used a ton. I see hydralazine much more commonly. One really important thing to note as far as cardiovascular function goes is these medications, because they are direct-acting vasodilators, your body wants to tend to compensate and get that blood pressure back up again. And what it will do is it'll act on the heart. Okay, so the two big things that affect blood pressure are the heart rate, how fast and how hard it's pumping. So that can raise blood pressure. And then the other end of it is the vessels, how open or closed they are. If they're more open, naturally that's going to lead to a lower blood pressure. If they're more closed and tightened off, that's going to lead to a higher blood pressure. So when we use a direct-acting vasodilator and just affect the vessels, the body tends to compensate, and you can get what's called reflex tachycardia from the use of these medications. Okay? So that rapid vasodilation by the drugs, it can trigger that sympathetic nervous system activation and ultimately increase heart rate and contractility. So because of that reflex tachycardia, it makes a lot of sense to utilize a beta blocker, which is going to act on the heart and help reduce the risk for that kind of overstimulation or that reflex tachycardia. So that combination, you will see some for sure there. Other adverse effects, things to think about with these direct-acting vasodilators. They may cause a little bit of sodium and water retention and lead to a little bit of swelling. So that's something to pay attention to if you get too much of that. Obviously a diuretic in combination might be beneficial there. And then hydralazine, I've seen this come up a bunch on exams. Hydralazine is associated with drug-induced lupus. This is a classic board exam question. Symptomatically, if a patient is experiencing this, pay attention to kind of some muscle soreness and achiness, potentially joint achiness as well. You can also get a fever, and the lab that we can assess here is ANA, and that stands for anti-nuclear antibody. Okay? And this is also a common screening test for certain autoimmune diseases as well. So that positive ANA or the elevated ANA, that could be indicative of that systemic lupus type reaction. Minoxidil, one of the biggest things to note about this medication is it can cause excessive hair growth, which obviously could be problematic, depending upon the patient population that you're talking about there. Could be beneficial for some as well. But this explains why it's used commonly as a topical agent for alopecia or male pattern baldness. These medications, again, typically reserved for resistant or severe hypertension, where we've tried multiple other agents. Big downside, specifically talking about hydralazine, because that's the one that's used most often, is it does have to be dosed multiple times per day. And so that's a huge downside to this class of medication, and I guess more specifically hydralazine. It tends to be relatively safe in pregnancy, so if we're getting down the line, we need something to cover hypertension, and our standard agents aren't covering it in pregnancy. It may be considered in that patient population. Recall that ACEs and ARBs are a couple examples of meds that are absolutely contraindicated there. Hydralazine, the other situation other than hypertension that I've seen this used is it can be helpful in heart failure patients with reduced ejection fraction. So common combination here is hydralazine and isosorbide dinitrate. Again, we have some evidence of benefit in that setting. Typically, we're going to use our ARNIs and ARBs and other therapies first. But in the odd event, somebody can't tolerate an ARB, for example, this combination of hydralazine and isosorbide dinitrate may be a consideration there. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up a few practice pearls to help you get ready for your exam. So grateful for all of you listening to the podcast. Again, hoping you're picking up some education, that type of thing. If you got comments, suggestions, feel free to reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. If you like this episode, found it helpful, do us a huge favor. Share us with friends, colleagues, pharmacy students, med students, nursing students, anybody who could benefit from some pharmacology education. I greatly appreciate that. And of course, support the sponsor, meded101.com/store. Thanks for listening. Take care. Have a great rest of your day.